Hello people, in this video we want to look at dermatomyositis. So what are you understanding here? Itis, inflammation, myo, muscle, right? And dermato is skin. So first thing is muscle is affected, and then if there are some skin manifestations also, it becomes dermatomyositis. If there is no skin affected, then it will be called as PolyMyositis. Okay, so if skin is also affected, it is called as dermatomyositis. So what is written here? Look at this: skin changes with muscle inflammation. Also the blood vessel is affected. Okay, so skin changes along with muscle inflammation. Look at the word here: muscle is inflamed. Okay, muscle is what? Inflamed. And this guy should be more red, I feel, right? Wait, let's make it red. This guy is red. Okay, that's all we could do. So muscle is inflamed. There are some skin changes, and it also could have affected the blood vessel. So basically, why is this important? This could be the first presentation in some cancer like stomach and lung cancer. Okay, so this polymyositis, muscle weakness, muscle inflammation, or skin changes with muscle changes can be the first presentation of some cancer. But don't worry, it can also be due to some autoimmune conditions. Which cancer they're talking about? Stomach and lung. Okay. What else are we looking at here? Let's go down here. So basically, what and all muscles is it affecting? It is affecting skeletal muscles, cardiac muscles, smooth muscles. So it's affecting all types of muscles, and it is mostly affecting proximal skeletal muscles. Symmetric. So can you say this? Symmetric?
Symmetric.
Proximal.
Proximal.
Muscles.
Muscle.
Symmetric and proximal skeletal and all muscles are affected. Okay, so what is happening to the muscles? There is inflammation. Muscle is inflamed. So you can understand this: itis, inflammation, right? So in a DM, dermatomyositis, this DM is very bad. It looks like diabetes mellitus. Dermatomyositis. Okay, there is skin change also. So if there is no skin change, it's called as polymyositis. If there is skin change also, dermatomyositis. Very good. So what is this? These are anyways rare. And why does it happen? Because of autoimmune disease or malignancy. We already told you, right? So some people are smart. They're saying they can occur in isolation. That means they can occur without autoimmune disease or malignancy, is it? So that's where they confuse us. Okay, what are the clinical features of these people? Obviously, you know, they'll come with muscle weakness. And what type of muscle weakness? Proximal muscle weakness, near the trunk, whatever is there, that will feel more weak. And symmetrical it will be, both left and right. And lower limbs are affected more than upper. Why do I feel lower limbs are not so proximal, but lower limbs are more affected, they are saying. Okay, and 40 to 60 years of age, because this is any old age only, they will cells keep on dividing and then they will develop cancer. Usually cancer in old age, it will be more, right? So 40 to 60 years person will come to you. Guys, focus here. What the complaints will be? Will they tell you they have muscle weakness, proximal, symmetrical? No, they will tell you there's difficulty rising from chair, climbing stairs. They have muscle pain. They can have weight loss, fatigue, fever also. They can have some systemic manifestations. And they can have this because muscle is involved, isn't it? And we told you all types of muscles can be involved. So what if respiratory muscles are involved, pharyngeal muscles are involved? They'll have aspiration, where respiratory failure, they cannot breathe, right? Ventilatory failure, respiratory failure, you can say, is it? Intestinal lung disease, etc. And look at this, they can have esophageal dysmotility. Why? Because we told you just now, pharyngeal muscles, all muscles are affected, right? Guys, let's go back here and add the other disease. Breast cancer also can be a cause, okay? So let's, now we have finished what? We have looked at the clinical features, isn't it? Basically, we looked at the symptoms, right, that they come with. Now we will look at the signs. Okay, signs. As a doctor, what will you see? You will see that they have this kind of, on the joints, they have some papules. This is called as some Grotton papules, okay? So they are scaly, erythematous or violaceous, red or violet colored, psoriasiform plaques. They said papule, here they are saying plaque, okay, over the extensor surface. So this is your extensor surface of your hand right there, of the PIP and the DIP joints. That is the DIP, I know, distal interphalangeal joint, proximal interphalangeal joint. Very good, very good. So the hands, knuckles, everything you can see are affected. And periungual nail fold capillaries are often enlarged and tortuous. Very good. Then heliotrope rash is seen where eyelid. Okay, let's look at the eyelid now. Guys, heliotrope, this is very specifically they are using this terminology for dermatomyositis. Here it doesn't look violet to me at all. But what is heliotrope? Heliotrope is actually this flower, okay, which is so purple. So that's what they're trying to use this purple violaceous and all that word, violaceous, right? So basically they're just saying heliotrope. It's nothing but this flower. Basically this terminology, if you search in medicine, they are giving only for dermatomyositis. Okay, heliotrope rash. Heliotrope, where will you see? Sorry, heliotrope rash, where will you see? Dermatomyositis. Okay. It's a violaceous discoloration of the eyelid in combination with periorbital edema. It is not just there's a rash, okay, there is periorbital edema around the eyes. Around the eyes there is edema, periorbital edema. This sounds more like a kidney kind of a disease, right? Yeah. Okay, then similar rashes can be there in upper back, chest and shoulder. So upper back is this one and chest and shoulders in front. This is called a shawl distribution when you wear a shawl. So where will you see shawl distribution rash? Dermatomyositis, very good. So now let's go here. What are they trying to say here? In dermatomyositis, you'll have periorbital edema with violaceous eyelid rash. Yes, this is an ophthalmic feature of a rheumatological musculoskeletal disease. Yes, okay. You will see that there is some periungual involvement. Periungual means around the nail, is it? Periungual involvement. I feel they have blurred this fingering. Don't you think? Okay, and here they are showing you the photo aggravation. Note the prominent periungual involvement, erythema, dilated tortuous capillaries in the proximal nail fold. Oh yeah, see here? This one? Dilated tortuous erythema capillaries in the proximal nail fold. Ragged cuticles are features of connective tissue disorder. Is that what they are meaning? Ragged cuticles. So nails can tell you so much, right? And even intestine can be affected. You can see some submucosal, cyst, gas filled, etc. Because we told you, right, what is affected? Muscle, even smooth muscle, everything is affected. So this also can be there. Pneumo, some air cyst, air filled cyst. Okay, around the intestine. Guys, very hi-fi stuff there. Let's relax. So muscles are affected, skin is affected, blood vessels are affected. That much we know. Dermatomyositis. Why are they affected? They are affected because of, yes, say, they are affected because of malignancy, underlying malignancy or autoimmune condition. Or sometimes they can just be there without any reason. Okay, let's move on. This can also get calcified, they are saying. Calcium phosphate depositation, there can be some calcification here, they are saying. Okay, so what investigations you'll order for these people? Okay, first of all, they are saying that you need a muscle biopsy, but to know which area to take biopsy, you need an MRI. So MRI should be used to identify the place of biopsy. Okay, then you will take muscle biopsy. And how will the muscle biopsy look? Look at this. There will be, please muscle go back. See, this is the biopsy. So here they are showing you that there is necrosis, inflammation, and lot of infiltrates are there here of what? Of what? Inflammatory cell infiltrate. Okay. Then you have to check the serum creatine kinase level. This creatine kinase is sounding so much like a myocardial infarction levels. Creatine phosphokinase when we have, right? But remember that CK, MB and all what we studied, that CK, M and B, that is muscle and brain, isn't it? So M is muscle only. So still you can check this, right? Creatine kinase. And because even cardiac muscles are affected, even smooth muscles, skeletal muscles, everything is affected in this, isn't it? Okay. Although a normal creatine kinase does not exclude the diagnosis, standard. Even if it is normal, you cannot exclude the disease. Confuse the doctors. Okay, especially in the juvenile myositis. Okay. How's it going, people? What are you learning today? Dermatomyositis and that, yes, PolyMyositis in which skin won't be affected. Very good, very good. What are we looking at currently now? Investigations. What did you do in investigation? MRI, yes. Then biopsy, very good. Then serum creatine kinase level, very good. Then electromyography, study the electrical activity in the muscle, is it? So you can highlight whether it is a autoimmune, non-autoimmune, non-inflammatory myopathy. Okay, let's proceed. You can screen these people also. Okay, you can screen people for underlying malignancy. How will you screen for malignancy? You can check tumor markers, maybe you can do mammography, you can check for X-ray. Prostate specific antigen is tumor marker. We already told that if you missed it, right, people? So do CT, X-ray, just look for malignancy underlying. This is the investigation you will do for these people. Okay. Now let us go forward. conditions associated with positive anti-nuclear antibody. Here, slightly specific they have become. There's something called as anti-Jo1, 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 okay. Some anti-histidyl RNA synthetase. This will be their positive. This is a nuclear antigen. Antigen. I thought it's an antibody. Anti-Jo. Antibody. Disease. Okay. Antibodies to antigen. Yes, that makes sense. Anti-Jo1. Guys, anti-Jo1. Something is there. Some antibody against some antigen. Okay. Anti-Jo1. And what is it? You'll see it in dermatomyositis. Okay. This is a antibody to a nuclear antigen. Okay. So basically, these people will have Jo1 antibodies, anti-synthetase Jo1 antibodies. Okay. So simple, isn't it? These names to remember and understand. Wow. Okay. So let's go forward. What are the differential diagnosis kind of a thing? See, proximal muscle myopathy can happen in many causes. Okay, this is proximal myopathy. It can happen because of inflammation, endocrine, toxin, drugs, paraneoplastic conditions. So proximal myopathy can happen because of cancer. That is dermatomyositis. It can happen because of some hypothyroidism, etc. Cushing syndrome, Conn syndrome, that is primary hyperaldosteronism, isn't it? So because of a lot of things it can happen, but one of them is this dermatomyositis, paraneoplastic it is, okay. Proximal muscle weakness, why and all it will happen if they ask you, write all this, okay. That's the DD basically we are trying. And what are the other conditions that you will see in malignancy? This is a different type of DD. This is not a DD actually. In malignancy, what are the skin conditions can you see? You can say dermatomyositis, that you know. Very good, guys. Focus. What are we looking at? In malignancy, what are the skin conditions you can look at? Yes, dermatomyositis, we know. Generalized pruritus, acanthosis nigricans, which you also can see in insulin resistance, isn't it? Superficial thrombophlebitis and all you can see. Okay, anyways, let's move on. How will you treat this guy, dermatomyositis treatment? Steroids. Because it's inflammation, they're giving kind of anti-inflammatory. Looks like steroids, they're giving prednisolone. Then immunosuppressive, if it is because of all this immune, right? Methotrexate, azathioprine, cyclosporin. The spelling is so weird, right? Cyclosporin. Rituximab. Then they're giving IVIG they are giving. Okay, let's make some other special color for this. IVIG. Then they're giving hydroxychloroquine, mepacrine. See, if skin is predominantly involved, because now we are talking about dermatomyositis. If skin is primarily involved, then mepacrine, hydroxychloroquine, very doubtful that we'll remember this till the exam. Glucocorticoid induced myopathy can happen. This looks like a side effect. See, you try to treat myositis and it is becoming myopathy. Okay, so that is the side effect. They are saying very sincerely they accept the side effect. That's why I like allopathy. And main thing we see in other systems of medicine, no, they will say there's no side effect because they never tested for them. Okay, let's move on. There is something called as juvenile dermatomyositis. They are calling it as JDM. See, DM itself I don't accept because it sounds like diabetes mellitus. But anyways, so in this also it's same thing. But the good thing about juvenile dermatomyositis is there's no need to search for malignancy, because malignancy, we told you, around 40 to 60 years, those people are more susceptible to acquired, right, malignancy. So these people, no need to search for malignancy, they are saying. And how will you treat? Same thing. Methylprednisolone, IV, methotrexate, cyclophosphamide, IVIG, same thing. Okay. So in this video, you have looked at dermatomyositis. Bye.